Okay.
Well, hi, everybody. Welcome to this week's seminar. Today, I have the pleasure of introducing Dr. César Higgins, who's a wonderful postdoctoral fellow working with us in the Department of Neurology at Johns Hopkins. He does a lot of work that focuses on blood-based biomarkers to understand physiological pathways implicated in health equities as they relate to cognitive health. In his research, and what I think will become apparent from his talk, he emphasizes the implementation of modern causal inference methods to identify proximal mechanisms related to adverse cognitive aging. His research is highly disciplinary. He has training in medicine and epidemiology, and he gathers his expertise from different diverse disciplines. And so with that, I would turn it over to Dr. Higgins, who's going to talk to us today about his work on cumulative burden of depression and domain-specific cognitive impairment in the WISE cohort.
Thank you so much. Hi, everyone. I'm Cesar. This is a research project that I started working with Dr. Fitzgerald and Dr. Rubin last year. And I have presented at different meetings now, and pretty much the manuscript is almost wrapped. So I'm very excited to present these results to you. And again, in here, we're going to be talking about a new or a novel measure of depressive symptomatology and how to calculate the effect of depression on different cognitive domains using modern epidemiological techniques. I'm gonna go over the presentation, but if you have any questions, feel free to ask them. I don't have the ability to be looking at the chat, but I think probably Kay will be monitoring the chat. But if you really want to interrupt me and ask a question, I don't mind that. So with that said, I'm gonna make myself small here, and I'm gonna start. So again, the title of this presentation is Cumulative Burden of Depression and Domain-Specific Cognitive Impairment in the WISE study, a marginal structural model approach. So we know that people living with HIV are at increased risk of psychiatric comorbidity, and probably depression is one of the most prevalent psychiatric conditions among people living with HIV. It's also very common among people living without HIV, but chronicity of depression is correlated with also cognitive function and multiple impairments in different domains like memory, attention, executive function, processing speed, and other cognitive domain. But one premise is that women living with HIV might be particularly susceptible to depression-related neurocognitive impairment, because we know that the HIV virus have a predilection for the central nervous system, and probably the WISE cohort would be a good study to test this different working hypothesis. Again, in the left side of this slide, you will see what our conceptual diagram for working with in this study design is. And we really wanted to explore the effect of cumulative depression burden in a cohort of women and what its impact would be in cognitive impairment. As I said, we have different domains of cognition in this study, like learning, working memory, executive function, processing speed. There are around 7 of them. But the most important part is, well, if we truly want to identify that effect of depression and cognitive impairment, what are the confounding factors that might mask that association, and how do we want to adjust for them? And probably the technique that we implemented aims at looking at these confounding effects and then censoring effects. So, or censoring bias. So for those who are not familiar with what confounding factors are just factors that are related to both the exposure that we're looking at or the exposure of interest that we have in a study, and also the outcome of interest. And they create this backdoor path between the exposure and the outcome, and we really need to find a way to control for them. And there are many different techniques to do that, and the one that you will see today is one of those. So how do we assess exposure? So we talk about cumulative days of depression as the exposure for this analysis. And we know that it's very common for participants in this large cohort to undergo a variety of different depression measures, but in the WISE cohort, the depression assessment was done through the Center for Epidemiology Depression Studies scale. This scale ranges from 0 to 60 with higher values of the CESD score, indicating higher depressive symptomatology and lower values indicating lower depressive symptomatology. So how do we transform this scale that goes from 0 to 60 to days with depression? So we did a linear interpolation. So, and what we did was those values of CESD that were greater than 33, we get them a depression value of 1. So meaning these people that have CSD values greater than 33 will receive at their visit a value of 1, meaning they do have a high burden of depression, or they do have a high burden of depression symptomatology. Those who had lower levels of CSD or those who had a value of CSD less than 9 receive a depression value of 0. And if you score anywhere between 10 and 32, then you receive a similar probability of having a depression value between 0 and 1. As you can see, anyone that scored between those scores then receive a proportional depression value. So what we did is we use this scale, these new depression values, and we multiply it by the time that have transcribed between visits. So what we did was in the WISE cohort, CESD scores are evaluated every 6 months. So we could look at the time that had elapsed between visits. On average, that's how they are assessed. So for example, if a participant had been followed by 180 days between 2 consecutive visits, we took the average of depression values between those 2 visits. For example, if the average depression values between the first and the second visit was 0.5, and we know that on average people come 180 days later, then we multiply 180 by 0.5, and then we get that person had on average 90 days with depression during that period. And then what we did was just add up the numbers of days with depression that transferred during the follow-up in our study. So this novel metric of depression, instead of telling whether a person is depressed or dichotomizing the CSD score, really captures the cumulative burden of depression over time. Oh, sorry. Okay, so how did we design the study? So again, the WISE cohort, the Women in HIV Interagency study, is a large prospective longitudinal study in the US that started in the 80s, and people come every six months for visits. And I think around the visit number 20 or 30th, people start coming every 2 years for cognitive assessment. So the way that we organize this, we took the first visit and we follow people up until their first cognitive test assessment. The first time that they had a complete cognitive test battery, and that would be that they had assessment around 7 different cognitive domains. As you may see, there are different issues with following such a large cohort that comes at different times. One of the issues is that we have differential time for measuring the outcome. In this case would be the complete cognitive test battery, right? There will be people who have for example, their first complete cognitive test battery at visit 30. There are other people who have at visit 40. There are other people who would even have it later. So we have 2 issues with that. The first one is that people who had earlier visits or early complete cognitive test battery, we will be more likely to have more times to have a subsequent cognitive test score, right? And because we're going to be following people until they develop impairment, then people who have later visit, we have less time to be lost to follow up, because probably they came later they were enrolled later in the cohorts, they don't have like that next follow-up visit yet. So we have the issue that we have differential time of follow-up, right? And then differential time at which like censoring happens. So if you, as you might expect, a person who received, for example, complete cognitive test value at visit 40, you have at least 2 more cognitive test assessment. So they were very more likely to be lost to follow-up than a person who received a complete cognitive test value later on. And so what we did was we followed people either until they have a complete cognitive test assessment or they were considered cognitively impaired or they were lost to follow-up. So they were considered cognitively impaired when they scored 1 standard deviation below the average mean score of a particular cognitive test score. So we have 7 different cognitive test scores. So you may see that cognitive impairment was assessed for each score for each cognitive domain separately. And again, we consider the cumulative state with depression or the depression border as we follow people from the first visit until the first complete cognitive test battery. So the exposure was assessed only until the first complete cognitive battery was completed or taken. So let me continue. So as I have said, we have 2 issues when we try to identify then the effect of cumulative burden of depression on cognition. The first one would be the confounding factors that are associated with both the exposure and the outcome. And you might think of this, of any factors that could have a backdoor way path between these 2 variables. That could be factors like BMI, drug use, certain behavioral risk factors, right? Like alcohol consumption, exercise, etc. There are like other factors associated with HIV infection, probably like CD4 count, receiving antiretroviral therapy. All those factors, then we can think about confounding factors. And then we have really good data, then we have assessed them in the data, and we shouldn't be too worried about that. But there are also unknown factors, right, that could be associated with our confounding factors and cognitive impairment. The good thing about this graph is if our data have enough confounding variables identified, and we believe that all these variables that we identify are related with these unconfounded factors, once we control for it, then we could also close this other backdoor path. Another issue that we have with the data is that of sensory. So as I said in the beginning, we have the problem that people come at different visits, or it's not a problem, but it's just a feature of the study design, right? People come at different visits. So those who come at a later visits probably have less probability of being censored because they don't have a next follow-up until 2 years later. But people who came at earlier visit are more likely to be lost to follow-up. So in this case, then the timing at which the outcome was measured is associated with censoring. We also can think about people who actually have a poor cognitive function will be more likely to be dropped out from the study too. So in that case, then cognitive impairment will be related with censoring. And similarly, we can think about, well, women that are having a big burden of depression, then they will be less likely to be retained in the study. So if we select our study participants based on a sample that is not censored, meaning that we only include participants with complete information on everything and we ignore censoring, then we create what we call selection bias issue, or we call it this in epidemiology to collider stratification bias. In this case, when we have a variable that is receiving 2 errors on it, and we stratify on it or control for that, then we'll be creating a selection bias issue or collider stratification bias issue, in which we will be inducing an spurious relationship between the exposure and the outcome. So we want to control for both things in the study, with analytical tools. We want to control for confounding and censoring. And we do that through marginal structural models. As you can see here, this is a simple equation of a marginal structural model. And if you think about regression, you will have, right, your exposure in here is denoted by the letter A. In this case, our exposure is cumulative burden of depression, and our outcome would be think about one of the 7 impairments of our outcome, right? And we would like to look at the difference between, for example, high burden of depression denoted by 1 and low burden of depression denoted as A equal to 0. So we want to look at what the effect of high burden of depression is on the outcome, right? So in a regular regression analysis, you will have a bunch of covariates here adjusted for. In a marginal structural model, we have adjusted for those covariates by a weighting technique in which we render those covariates independent of our exposure. So we don't need to include them directly as in regression in the data, but we do it through weighting. And that allow us to calculate truly the average causal effect that it's between depression and cognition. And again, that average causal effect is based upon the assumptions that we have control for all confounders that could be thought of between our exposure and our outcome of interest, and that we have closed these backdoor pathways. But we call these models that we refer to these models as marginal structural models or marginal mean models, and that's where the name comes from. Okay, so how do we create this, or how do we render the covariates or the confounders independent to the exposure? So for that, we do inverse probability of exposure or inverse probability of treatment way. So I usually refer to A as exposure of a treatment. So many people call them treatment, but we're actually talking about the same thing. And again, the issue was this backdoor pathway. So I like to think about this with this graphical representation. Let's imagine that our outcome is dichotomized. Our exposure is dichotomized into high burden of depression and low burden of depression, right? So what we can think if the different colors in this figure are like different characteristics in the data set. Let's think about red being age, green being BMI, this, I think, fuchsia with being drug addiction, right? There are different characteristics, and there are unbalance between people who have low burden of depression and people who have high burden of depression. So we want to balance out those characteristics, like if it were a randomized control trial, right? When you have a randomized control trial, the randomization process balances those covariates out. But in observational data, we don't have randomization, so we have to use these statistical techniques to balance those things out if we really want to identify causal effect. So how do we balance them out? We weight this. We weight the probability of the treatment or the probability of the exposure based on the past, meaning based on all baseline covariates or the baseline confounder variables. So, and you can think about weighting as creating different magnitudes for each individual, right? For example, in this case, people with high burden of depression had more fuchsia color, right? And people with low burden of depression have less. But now the people who have less receive a higher weight in order to balance all these covariates across the two, the low depression group and the high depression group. So that's the idea with it. And once we have them balance them out, then we can render the confounders independent of the exposure, and the backdoor pathway that was open, then it can be closed. So we do that through inverse probability weight, and I wanted to show you how that works. So let's say that we dichotomize exposure, like the percent of days with depression between greater than the 75th percentile and indicating high exposure to depression, and below the 75th percentile as low depression burden. So what we do is that, as I said, we can create a model, like a logistic model, that predicts the probability of the exposure, meaning having high levels of depression based on its past, based on all the covariates. And that would be like a propensity score kind of. And then what we create is like, if this is correlatively balanced, meaning if the treatment or if the exposure, right, is independent of all the covariates, then we will say that the probability of having high depression or low depression would be close to 0.5. Just like imagine going to a randomized clinical trial, and then your probability to be assigned to treatment or placebo will be similar to 0.5. So then, on average, the weight would be 1/0.5. It means that the weights for this population would be around 2, which is what we get in here. I just wanted to show you that the mean average weight would be around 2 if we did this process well. And we can calculate the same, what is the weights for the unexposed would be 1/1 minus the probability of being assigned to 1, A=1, given the pass of or the covariates. So that's how we do it. It's a very simple procedure. But then we can also, we call this unstabilized weights, but we also can just have a numerator that is equal to the probability of receiving treatment for the exposed or not receiving treatment for the unexposed. And then these weights will be very close to 1. And we call this stabilized weights. So now we got rid, when we take the inverse probability of exposure weights, we took care of the confounding part of the issue, right, of the puzzle. Now we need to address the problem of censoring, right? And we're going to treat this problem of censoring very similar to what we did with confounding. We can also create inverse probability of censoring weights. So in this case, let's call the brown or the gray folks in here that they were censored. The green ones were not censored, right? So, so what we see is that there is an imbalance between those who have low depression and those who have high depression. It seems like those who have high depression were more likely to be censored. So what we're going to create is a pseudo population where censoring didn't exist. So some people are going to have more values than others to balance that out, like the probability of being censored in one group and versus the probability of being censored in another group. When we render then the exposure independent of censoring, again, we get rid of this error, then we now calculate the true effect of cumulative depression burden on cognition without censoring, pretty much. Like thinking like, okay, there is no censoring on this population, we have addressed it through inverse probabilities of censoring weights. The big assumption is that the confounding factors that we use to address censoring truly then have to account for the censoring probability. And again, when I showed you the first marginal structural model, I omit the fact that we were saying that, okay, that marginal probability or marginal structural model didn't include censoring, right? In here now we are addressing the censoring part of it by creating inverse probability of censoring weights in the population. And we did it exactly the same way that we did it for inverse probability of exposure weights, just that people who were censoring will have a weight of 0, and people who were uncensoring will have a weight of 1 over the probability of not being censored, given both the exposure and the covariates that we capture in the data. And on average, again, those weights are going to be 1 if they are stabilized. So I just divide in here, and 2 if they are non-stabilized. But I just divided here, then I just took the numerator of the probability of being censored given the exposure. And again, the denominator with the probability of being censored given the past covariates and the exposure. One characteristic in here is these, the observations here are reduced with regards to the first approach that we used, because in this population, we're creating a pseudo population in which censoring does not exist, and censor participants will receive a value of no weights, pretty much, or they won't have any weight, so they will not be included in the analysis. So what we do then, because those two techniques are independent, we just multiply them and calculate a final weight for the entire population, and then we use a structural marginal model, and pretty much is running a regression weighted by the weights that we just calculated or estimated. And we did that for both HIV positive, HIV negative participants, and then the overall samples. And we look at the cumulative burden of depression as the percentage of day that a person had depression over the study period. That is from the first visit to the first complete cognitive test battery. And we observed that, for example, if you were 1 standard deviation above the mean levels of the percent of depression of the sample, then on average, those people had a 24% higher risk of developing attention or memory impairment. That is being 1 standard deviation below the cognitive test score of that particular domain.
My
And
apologies. I'm sorry. You said now who was the one that developed a higher cognitive of learning and verbalness?
can you repeat the question? Sorry.
Which group did you say was had the highest of verbal and basically learning or memory?
So what group, meaning the HIV positive or the HIV negative?
Yes, I was trying to see which group were you talking about, positive or negative?
Okay, so sorry. And here first, I was talking about just the overall sample, ignoring serum status, right? So the blue one, the blue dog, great question. The blue dog is everyone in the sample, ignoring HIV serum status, and then the red would be HIV positive, and the green would be HIV positive, and then the orange, kind of reddish, would be HIV negative participants. So here we have the effect stratified by each one of those 2 serum status and then in the overall sample. So for attention or working memory impairment, we see that the effect really doesn't differ by serum status group. It's very similar, and it's a little bit smaller for the overall sample. And in fact, for this dotted line, it's 1, so meaning if the confidence interval cross that line, then we don't have really statistical meaningful results, but everything that is to the right would be considered statistically significant, right? So we do see that the effect of depression on each one of these cognitive domains are very similar across HIV positive and HIV negative, with the exception of few cognitive domains. So, and that goes to second question is, does the effect of depression on cognition differ by serum status group? So in that case, what we did was an interaction term between our measure of depression and then HIV positivity or serum status, right? And then we didn't find actually that there was any evidence of effect modification in any one of the domains of that. Those are all the parameters for each one of the 7 different domains. And this highlighted band is the ones that have like the interaction term between the exposure and the HIV status, and none of them were statistically significant. So we did not have really evidence of effect modification by status. But what we can observe is that cumulative depression burden do have an effect on attention and working memory, verbal learning, executive functioning, and to a lesser extent, verbal memory and verbal learning too. So any questions so far? Well, we also look at the probability of impairment across different thresholds of the cumulative burden of depression measure. So we look at it between having 0% of the days with depression to having 100% with depression. And we look whether there were different trajectories between HIV positive and HIV negative individuals. And we found that, for example, in the case of attention, as the days with depression increase, then we can see that there's some statistically significant difference between positive and negative. For example, from 0 to 30% of days with depression, we see that they were different, but then after the decrease of depression keep increasing, we saw those confidence intervals start getting wider and wider, and we were not able to detect differences in search status. And again, we only observed that for attention, and we observe it slightly for motor function here in the beginning, but not at the end. Most of these confidence intervals truly overlap, indicating that we need more years of data. And the way that I see this is that this sample is relatively young. Like most people, I think the average age in the sample was about 50 something. So, so the way I see it is to start truly see those those differences between motor or speed or verbal impairment or any of these domains, we have more years of cognitive data. I mean, we follow these participants for at least 12 years from the first visit to the first cognitive test battery. But after the first cognitive test battery, I think we need more years of data on cognition to truly start seeing those differences. And again, I think it's because these are relatively young participants, and cognitive decline usually, what in my experience or what I had worked with an older data, starts like around 65. So I think there's some years of data to look more to truly say that there is no difference by sever status. And that's just my take on that. So in conclusion, the increased burden of depression is related with cognitive impairment in attention, memory, executive functioning, and learning. Women living with HIV exhibit a slightly higher risk of cognitive impairment across multiple domains, but we didn't find any statistical significant evidence of effect modification. And we can say that then addressing high burden of depression in women could have a positive implication for cognitive health and brain health. Where do I see this moving forward? So I think for the research to explore what the biological mechanisms linking high burden of depression to cognition is. And for that, we can implement other causal inference techniques like causal mediation analysis could help us really look at or elucidate what are the physiological pathways linking depression to cognitive health. And not only the physiological pathway, there could be a structural pathways, right? I was called into attention to maybe gender violence and all these things that really could affect depression could also have an impact on cognitive health. So we can use mediation analysis to look at those different pathways too. And with regards to me, I recently received an Alzheimer's Association grant to keep looking at biological pathways linking structural inequities with cognitive health. So I plan to continue exploring the role of different metabolites and cognition in the WISE cohort. And then I'm going to leave you with this summary. Longer exposure to depression do have a negative impact in individuals' cognitive ability, at least in women. That's what we observe. And for that, we conducted our largest study of around 2,500 women to explore the role of cumulative depression burden over the study period and cognitive impairment. And in general, women who experience high depressive symptoms also experience deficit in attention, executive functioning, learning, and memory. And that is after accounting for all those confounding factors and selection bias issues. So with that, thank you so much to my mentors, Dr. Fitzgerald and Dr. Rubin, for their mentorship during this project, and the collaborators of the WISE cohort and the participants of the WISE. So thank you.
Thank you, Cesar. That was great. I will open it up to any questions. That you have a couple questions in the chat, but if those individuals would like to ask their questions directly, you feel free to do so. Otherwise, I can read them from you.
I can ask my question directly. Cesar, that was, first of all, I really enjoyed your talk and congrats on your new grant. I had two questions. One, when you enroll patients, if they have significant cognitive deficit coming in, do you still enroll them?
So because the first assessment, right, we have the entire battery, so they could have had cognitive impairment at their first assessment. So that would be no problem for this study. So yeah, we didn't discard them for having impairment in their first visit.
Or Barb, just to chime in, or are you asking about whether they had cognitive, because these are just, it's an observational cohort study. So it wasn't based on, say, cognition. So that's the downside is whether there's true cognitive impairment. I think the only way you can do it is if people were not impaired and then you had that kind of incident, but you still wouldn't know if there was a problem early on. So that's
right. Yeah. I understand now you're pointing out that it's an observational study. I was thinking about it as design. And my other question, which is also now I think Leah already answered, but I was asking if you or others have looked at inflammatory biomarkers and how they correlate with either depression or cognition in such studies. Why are you laughing? Is that a bad question?
No,
it's a
it's
great
what he's
question.
thinking about.
That's what he really loves that.
Yeah.
Right. Yeah, that's something that I had also asked Dr. Rubin. It's like I work in my dissertation, I work with different cytokines and cognitive impairment. I haven't done it under depression, but I did find a significant effect of different pro-inflammatory cytokines and cognitive health in an older cohort of retirees. But yeah, that was my question, was whether this pathway could be mediated through different inflammatory biomarkers. I think that that's an important question and should be addressed in the future.
And Barb, Cesar actually sent me an email, are these available? And that's kind of the question. We have to go back to the Data Analysis and Coordinating Center to find out what's available when, or if not, Cesar, that's a good idea for a pilot study, right? Where you might be able to leverage samples to do that.
Thanks. Very nice. Thanks.
Any other questions?
I think there are a couple more in there.
Yeah, I can go
Yeah.
with the chat one in
Yeah,
case.
I have a question. Can I ask a question?
Yeah, go ahead, Wei.
Yeah, nice talk, Steve. In your research, actually, you're focusing on the causal relationship from the depression to the cognitive impairment. But do you consider that there's a possibility that the causal direction is like the other way around? Like it's first because of cognitive impairment and then cause the depression, or maybe that for some groups it's this way, and for the other groups maybe the other way.
Yes, I mean, that's a great question, honestly. I think it's a very difficult relationship to parcel out, because if what we believe, which is what I just presented, is true, meaning if depression really is affecting cognitive function, then declines in cognitive function could also lead to depression. But one thing that I do think that is a strength is that these folks are being started being following on average 10 years prior to their first cognitive test assessment. And I think it's very unlikely that they have cognitive impairment so early on in their life. So I do think that that's kind of like the strength of the study. Is like, hey, we start looking at these folks very early on. But again, if we truly believe what we're seeing, I do think that that's one of those cases where I think it's like co-determining. Like, I think if depression have an effect on cognition, also the cognition can have later effect on depression symptomatology. So it's a hard question, honestly. But again, because of the long period that happened between the first depression assessment until the first cognitive test body was taken, I would think that the relationship is in the direction that we pointed out, like in the errors that we draw. I don't know, Dr. Rubin, do you have any comments on that?
No, it's that chicken or the egg. And unfortunately, you would really like to have cognitive assessments at all of these time points. So I think one possibility, not perfect, and it's in the opposite biological sex, is to look within the max that had, much like cognitive data that was captured early on and longitudinally. But it's, ideally, it's a tough one. I saw Carl Goodkin on here who focuses in this area as well. But I think Wei, you probably also mentioned it because you and Yan Shun are working on the development of new methods for causal modeling. So you guys should definitely, I know you will talk. But yeah. And then
it might be an opportunity for like depression polygenic scores, like your polygenic risk for depression, and looking at how that, because that's unlikely to change, right? How that might influence developing like cognitive impairments. So using that kind of as an instrument. And
that was part of your concept sheet. So that's totally doable.
Yeah.
Of course. Okay. And then Andrea had a question about what are the ages of the participants?
Right. And I think it was already answered. I think you all said that it started at 50 plus.
So
I'm
sorry, Andrea. The base, so the average age at first cognitive assessment was that like 50 something. But if you think about when they started 10 years prior, then that would be how on average the cohort was like 41 when we took the first depression status. So I just wanted to clarify that.
Okay, so it's actually started in the 40s. Now, how much was there a study that was alongside of that of how much hereditary like things like early onset dementia and Alzheimer and all was in these families as well that may contribute to the actual cognitive decline?
I don't know if we have data on family history of Alzheimer's. I know we had data on medication, Alzheimer's use medication, and for this sample, nobody was using Alzheimer's use medication. That I do know. But I'm not familiar whether the WISE cohort has data on family history of Alzheimer's.
Okay.
And I think Carl has his hand up. Do you want to?
Yes, thank you. I think this is excellent work and really focused on an important aspect of what we need to push our progress further in the field related to, particularly in terms of thinking about depression as a chronic exposure. But with reference to that, I thought I might bring up a few points of discussion, one of which is that depression, at least in terms of major depressive disorder, is an episodic disorder. So looking at averaging over time might be an issue in terms of that, in getting best estimates of cumulative depressive burden. There have been studies reported of total days of major depression. Life history data in which it was related to hippocampal atrophy, for example, which is, of course, of special interest related to an association with neurocognitive impairment. So that was one thing I thought I would ask. And the other was a bit more about the choice of the CESD or potential limitations. You're using a pretty high cutoff there for the total score for depression being present. And the CESD also doesn't have certain items it covers, like it doesn't have a suicide item on it. So one aspect is looking at perhaps rounding out the focus of depression further than the CESD, which also is used as generally for the past week. And when you're looking at syndromal depression, you're usually looking at 2-week, lengths of time to define ongoing depressive symptomatology. So just some thoughts there.
Yeah, no, I think that those are really great. And I think that some people were concerned also about the timing of that week prior, symptoms 1 week prior. And that's what that was in prior studies that have used this technique within WISE. They have been using the average between 2 visits. I think that have less assumption about, okay, well, we're taking how you were at this visit, how you were at last visit, and probably an average between those two is a fair assessment of what your depressive symptomatology during that period would be. I think that can get around a little bit of that, but yeah, I agree with the issues you're mentioning about using the CSD score. But also these are the way I see it, it's too like this is a large observational study. We're doing like a more tailored assessment of depression, and depressive symptomatology could be not only more time consuming, but also more costly. And I think that when we work with these large cohorts, I mean, we have to be ready to make these strong assessments and commitments, So I don't feel pretty bad about how we dichotomize it again, because or the cutoff point that we use, and mostly because other people have used it before too. I know that that's probably not a very straight answer, but at least, again, taking those average values between 2 visits help me conceptualize this a little bit better, in the sense, okay, well, at least, we have what we think could be your average scores between this time that we're following you up. And yeah, and with regards to the comment that you're saying that depression is more episodic, yeah, then I think in that case, we'll just take in the cumulative numbers of days that we have without regarding the free days without depression. But I still think that's very telling, because the way I see it is I don't know that measurement for days lost to disability. There is a measurement of like years lost to disability, right? When a person gets a disabling condition, I think econometricians tend to have that measurement. I see this cumulative burden of depression as similar to that, right? If you have an average depression burden of 20% and we have followed you for 10 years, that is very kind of the amount of time that probably have gone on your life with a very disabling condition, which is a mental health condition, right? So I think it helps me capture that in that way, rather than just say, oh, you have high symptoms, you have low symptoms. It's like telling me how many days kind of were lost to high depressive symptomatology. Even if you're very productive on those days, I do still think that just the fact that a person have recurrent thoughts of depression it's very telling. But yeah, I think your comments are very on point.
Well, thank you. I was going to say thank you, Cesar. I think this is a really novel approach, and it's the kind of approach that we need to advance the literature more. And I'm just trying to, see what ways of expanding the ways you're tapping depression could be further enhanced to do that. And also, thinking about depression in terms of dimensions of depression, just like we do with neurocognitive impairment in terms of domain. And looking at dimensions of depression versus cognitive domains might be a way to further advance what you're doing.
Right. I agree.
And I was just going to chime on to what you said, Carl. So part of the, as you know, with the CESD, there's all of the somatic items which people can be, endorsing, not just because of depression, but for many other reasons. And I've seen work by Judith Cook and others that have actually used higher cutoffs, I think, in some of her earlier work. So I think that kind of helps to get around that. But I think we're all on the same page that we need to start digging into that heterogeneity.
And then the last question is from Nicole, and I think you kind of hinted at this, but they ask, I'm curious how you arrived at the CSD cut points you used in this analysis. So less than 9 or greater than 33.
Yes, I think that there are a couple of publications, and I think one of them is within the WISE. They use exactly this cutoff point. So we just follow with what previous assessment had done, pretty much. So those were established before we did, and I just follow with them, pretty much. Yeah, there was 2 studies done in the WISE. One was with mortality, and did this assessment, and the other one was with factors associated with HIV management, or management of HIV medications and all those things. So they use exactly this cutoff points.
Great, thank you. Great. I think we still have a little bit more time if anybody else has any other questions, but.
And I think if not, I think is Dr. Daskib speaking next week. And I think Caroline, you have the title of the talk.
Yes, so she's talking about data science methods and their application to clinical and biomarker data in people with HIV. So data science methods.
So we're super excited to hear from her next week and start, again, excellent work. It's fun to see how this has kind of progressed from start to finish. And I think a lot of the comments here and factors like polygenic risk score, I think you may have that data, Kate, that can be integrated, or if not, we have to go through that process of getting that genetic data, which, as Barb Slusher knows, is not the easiest. But definitely, we'll look into these other factors for you. But thank you everybody for attending our second week. We're off to an awesome start, and keep going. So have a great rest of your Wednesday. Thanks, Kate, for moderating, and we'll see you soon. Bye, guys.
Bye.